Hello, my name is Janessa Pafford, and I will be presenting my D&P project on quality improvement project to determine the prevalence of sleep apnea associated with mild cognitive impairment. My committee members, my chair is Dr. Gordon West. My second reader and my community member is, her name is Cindy Keller. She is the social worker that I work side by side with in my clinical practice every day. Looking at the background, the practice of prevention through screenings is becoming standard in primary care clinics. The use of screening tools has been effective with determining risk factors for various medical conditions, identifying risks for diagnoses, and working on preventing from worsening or occurring altogether would be optimal. It's estimated that 25% of the adult population has sleep apnea, and only 1/10 of those are diagnosed. Sleep apnea is a treatable condition, contributes to the worsening of other diagnoses. Untreated sleep apnea can lead to memory loss and further development into mild cognitive impairment. There's been an increase in scientific understanding of how sleep apnea impacts mild cognitive impairment. Treatment for memory loss, unfortunately, has had few advancements over many years. So focusing on prevention of memory loss rather than treatment may provide further advances. Looking at the purpose and aims, the purpose of the scholarly project was to diagnose sleep apnea in the population of patients within a memory clinic in the Midwest region of the United States who have a diagnosis of mild cognitive impairment. The aim was to identify the occurrence of the diagnosis of sleep apnea in that mild cognitive impairment population. Other aims of this project are definitely more long-term. The end goal would be to demonstrate a lesser rate of progression or actually maintaining a higher level of cognitive function for a longer period of time from diagnosis of mild cognitive impairment to advancing into a diagnosis of dementia. For the purpose of evaluation, a home sleep study was utilized. It is actually much more cost effective than the gold standard lab polysomnogram and is a lot of times preferred by patients with sleeping in the comfort of their own home versus staying overnight in the sleep lab. Looking at significance, Chin and Kramer, they believe that most effective nursing care implements all patterns of knowing. I'm going to focus in on two of those patterns of knowing that I noted to impact my patient population the most, and that would be aesthetic and personal knowing. Through aesthetic knowing, as nurses, we know patients can be resistant to treatment or care if they don't have a full understanding of the disease. We're able to use our knowledge as nurses to teach the patients about their disease process and how it can actually impact their overall health. If we help them understand the full impact of the disease process on their health as a whole, I think it actually helps them more realize the importance of treating it. Through personal knowing, we're actually able to identify with patients and really make that connection through personal experience and personal knowledge. Using our personal knowledge, we can understand the patient's perspective about conditions like sleep apnea. Some patients look at the diagnosis and they assume that they're being targeted due to their body habitus. If we're able to actually help the patients understand there's more than just obesity that is related to a condition like sleep apnea, it could improve their attitude and willingness for further evaluation. The PICO question that I posed for this project is, in patients age 65 or older with a new diagnosis of mild cognitive impairment within memory clinic, How many patients with a stop bang of 5 or greater undergoing a home sleep study compared with a number of patients with stop bang 5 or greater prior to implementing the quality improvement standard have a positive result of sleep apnea? Looking into the literature review, there were three things that I focused on, and it was comorbidities related to sleep apnea, the association between mild cognitive impairment and sleep apnea, and risk factors for mild cognitive impairment. There are several comorbidities that are associated with increasing risk of sleep apnea. Sleep apnea has been found as a causative factor in inflammation, incidence of myocardial infarctions, and cognitive impairment. Advancing age has additionally been identified as a risk factor for sleep apnea. The relation between sleep apnea and mild cognitive impairment is actually becoming quite a bit more established. Poor sleep patterns, inflammatory responses in the brain, hypoxic episodes, and chronic microvascular changes in the brain are all factors that have related sleep apnea to mild cognitive impairment. There are shared risk factors between the two diagnoses. Untreated sleep apnea actually increases the risk and incidence of hypertension, cardio, and cerebrovascular events, and mild cognitive impairment. Poorly controlled hypertension, myocardial infarction, and stroke are not only related to untreated sleep apnea, but can actually lead to mild cognitive impairment. There's also actually been a lot of research on the relation between mood changes, such as depression from untreated sleep apnea. Depression can be a result of untreated sleep apnea and has been linked with increasing the risk of developing mild cognitive impairment over time. This was a quantitative exploratory research design looking in at the methods and design. A retrospective chart review was utilized in collecting data. The project had a focused population within a memory clinic, including only those that were newly diagnosed with mild cognitive impairment. The project included 22 patients aged 65 to 89, including both males and females, and actually had 100% of the population being Caucasian. A data collection tool I created following my extensive literature review. I developed this through an Excel spreadsheet, and the stop bang questionnaire was utilized to help determine the risk level a patient was for having sleep apnea. This is the stop bang questionnaire. Looking at this, it's comprised of 8 questions assessing for snoring, tiredness, observed apneas, hypertension, obesity, age, neck circumference, and gender. There's a point system that's used based on these criteria, and each positive response results in 1 point. The higher the point total, the higher the risk of sleep apnea. Obesity is defined as a body mass index of 35 or greater. Age is defined as being 50 years or older, being older or greater than 50 years. Neck circumference is determined for females to have a neck circumference greater than 16 inches, and for males, it would need to be greater than 17 inches. And then, unfortunately, being a male actually gives you a point. The research sample consisted of a total of 22 memory clinic patients. These 22 subjects, they were actually placed into 2 separate sample groups. The first sample group was from pre-intervention, and it consisted of 10 charts between the dates of November 1st, 21 through January 31st, 22. And an additional 12 charts were reviewed for the post-intervention group between the dates of February 1st, 22 and April 30th, 22. Looking at the inclusion and exclusion criteria, for inclusion, the electronic medical record needed to have documentation that the patient is between ages 65 to 89. had a new diagnosis of mild cognitive impairment. Stop bang score of 5 or greater needed to be documented in the flow sheets, and they needed to have received care either during the pre or post implementation timeframe. For the exclusion criteria, if the electronic medical record documented that a patient is less than 64 or greater than 90, had no diagnosis of mild cognitive impairment, or the diagnosis was already established prior to the pre and post implementation timeframe, excuse me, if their stop bang score was less than 5, and if they fell outside of that specified time frame, I ended up just closing the chart and did not retrieve any data. Looking at data analysis, the calculation of power was 0.069107. This actually determined the findings to be low in strength. Due to my small population, the confidence interval ended up being quite wide. The lower interval limit was at negative 0.3563, with the upper limit falling at 0.4230. With 0 being included within that interval, there is not sufficient evidence to show a change. Prior to collecting the data and during the consult with the statistician, it was actually determined that in order to be able to consider the data statistically significant, there needed to be a power of 0.8 to reach a statistical significance of 0.5. Also, pre-collection determined in order to have a large enough sample to justify statistical significance, I would have needed to have 154 participants. Due to limitations, including the time restraints and my highly focused inclusion criteria, only 22 participants were able to be included, as I previously mentioned. Going into the results, the total number of patients meeting the inclusion criteria and having stop bang score of 5 or greater was 22. 12 of those patients were post-intervention. The intervention did not demonstrate an increase in ordering. The intervention did demonstrate an increase in ordering home sleep studies. As shown on the graph, the pre-intervention patients identified at risk totaled 10, with only 3 of those patients having that home sleep study ordered, while the post-intervention patients at risk totaled 12, with all 12 of those patients having the home sleep study ordered and recommended to be completed. Looking further at the results, there was not a significant change in the rate of diagnosis of mild cognitive impairment, of sleep apnea in the mild cognitive impairment population. As a result of this project, looking at the graph, you can see that there was a significant increase in the ordering of home sleep studies, occurring similar to the prior slide. 100% of patients were assessed for sleep apnea post-intervention, with only 50% of those patients completing that evaluation for sleep apnea through carrying out and completing that home sleep study. Only 30% of patients were assessed for sleep apnea pre-intervention, but 100% of those patients successfully completed the home sleep study, and 100% of those pre-intervention patients who completed that home sleep study had a diagnosis of sleep apnea, whereas only 66.7% of the patients who completed their sleep study post-intervention were diagnosed with sleep apnea. Going into the discussion, the data analysis discovered an insignificant change in the rate of diagnosis of sleep apnea in the mild cognitive impairment population. The primary outcome of this project was unintended, but actually successfully identified patients with mild cognitive impairment at risk for sleep apnea, and then actually having them evaluated for it, or recommending and ordering it at least. Uh, Looking at strengths and limitations, conducting the research through completing retrospective chart reviews, it offered a more objective look at the data with less room for any interpretation. The inclusion criteria were very specific and supported a highly focused population of patients. Data was collected through a data collection sheet that I developed myself as a researcher. I was able to use the data collection sheet to help me in pinpointing the most valuable data to help support the project outcome. And with completing the retrospective chart review in compliance with ethical standards, all patient identifying information was omitted. And limitations, those also occurred. Due to the time constraints of this project, there were a limited number of patients who could be potentially assessed for inclusion criteria. As a result of my specific detail of inclusion criteria being that the patient had to have a new diagnosis of MCI or mild cognitive impairment, approximately 30 charts pre and 30 charts post implementation were actually excluded. Had my inclusion criteria needed to be met only including a diagnosis of mild cognitive impairment, whether established or new, my sample size would have actually quadrupled. The specific limitations were not able to be lessened due to being too far along in the project to change inclusion criteria or increase the date range for data collection. Looking into implications, prior to the implementation of this project, there was no standard to comply with when evaluating patients in the memory center and screening for sleep apnea. Increasing the screening rate by 70% confirmed that there was a need for identifying the at-risk population of mild cognitive impairment patients that could potentially have sleep apnea. And by having this quality improvement standard applied in practice, it actually resulted in more than just the population of patients being looked at with the mild cognitive impairment being screened, but it applied to all patients within the memory center, regardless of their diagnosis. Memory loss, unfortunately, is going to continue to be a difficult condition to be treated. The lack of forward movements in research identifying effective treatments for memory loss gives way to looking for more ways to prevent it. Sleep apnea has been recognized as a potential contributor to memory loss and potentially a reversible cause. By increasing the screening for at-risk patients for a diagnosis of sleep apnea, there could be a reduction in patients that have their daily lives affected by memory loss. Going forward in the clinical practice, I would like to see the stop bang questionnaire used more routinely in primary care as a screening tool rather than a supportive diagnostic tool. What I witness currently is that when a clinician has a suspicion that a patient might have sleep apnea based off of other symptoms, they then conduct the stop bang questionnaire to determine what their risk level is and then determine if they should be evaluated, whereas I propose that it should be done preemptively. Future research should include an easier generalized population for application into clinical practice. In conclusion, when considering potential contributing factors to memory loss, sleep apnea, I want to be high on the list. The stop bang questionnaire is a cost-effective method of determining a patient's risk level for sleep apnea. And although this project wasn't able to demonstrate a statistically significant change in the rate of diagnosis of sleep apnea, it was able to successfully demonstrate the importance for screening for sleep apnea. The creation of a standard of care that includes routine screening for sleep apnea in the memory center is a step forward in applying the same standard of care across primary care and hopefully other specialties with no potential negative impacts to the patients with performing a screening questionnaire, as we perform many screening questionnaires, generally in primary care clinics like depression screening and so forth. Further research could be supported to expand on the population and setting. My recommendation is that future research should focus in on the primary care population of patients and establish the presence of the at-risk population within this more generalizable sample. I look forward to hearing your feedback and answering any questions. Thank you.